Good morning.
Good morning.
How are you?
I'm great and yourself.
I'm good. You real low, or is it me?
Is hold on. Let me see. How about now?
I hear you. You just low. Like I have my volume all the way up to the max, but it might
Really?
just be me. It might just be me.
Okay.
It might just be me. How you doing?
I'm doing great.
Good. How was your week?
Uh, Actually, it seemed to go by pretty quickly, which I didn't mind.
Mm-mm. Mm-mm. I agree. I agree. Didn't
How
mind at
about
all.
yours?
The same. There was a lot of travel this week.
Oh, that's right. That's right.
Good morning, Tanika. Good morning, Carmen. Yeah, that was a lot of travel. But it went really well. I'm gonna be interested in how this week goes with the holiday in the middle. Like that's just crazy. Do you have both days off, or do you got to come back?
I have to come back Friday.
I don't understand. Okay.
And the thing, like, I'm really trying to be good because I took the 2 weeks off in May for my training, so I was like, I can't, I don't want to use any more time, like not right away, maybe like in the second half of July, maybe. But I was really trying to make it look good, you know.
Okay. Not make it look good. Good morning, Vicky. Yeah, yeah. But it was good. It wasn't as hot as it was last week. Last week was
No, yeah,
unbearable. Oh my God. The whatever was in the air was just I just I'm glad you stayed in. It was
yeah.
horrible for people to breathe, just to be outside. I was reading an article just this morning about uh, us maintaining our vitamin D levels. And, when it gets real, real hot outside, people don't want to go outside. They want to sit in the air conditioner, and that can wreak havoc on our, most people think our vitamin D levels are just low in the winter because we're in the house. Well, I guess it can happen in the summer too, because if it's too hot and you don't want to go outside, then um, that's an issue as well. So,
And speaking of vitamin D, everybody says, "Oh, take vitamin D3 if you don't go outside a lot or to supplement." But
mhm.
there's a lot of um, information out there that you need vitamin D3 and another vitamin called K2 to help it metabolize. Otherwise, it doesn't really, you're not getting the full effects of it. Plus, and that segues into supposedly there's a new variant of COVID that is starting to kick up called, of all things, Kraken.
They about to get it cracking with the COVID. Oh my God.
Hmm.
No, I never heard about the K2. One of the doctors I follow, he always talks about have calcium and vitamin D that also helps to absorb it if you're taking supplements. So he always recommends that as well, but not Kraken. I hadn't heard. Look, I have noticed, particularly in stores, that people are actually masking up again, primarily workers in stores. And a friend of mine told me that her one of her children had a wedding in Alaska, and after the wedding, they decided to do like a small Alaskan cruise, and she got COVID on that cruise. She's like, they were doing everything they needed to be, but because we're, just all together, and folks don't mask as they did before, unfortunately, she said she got COVID. She said it wasn't really, really bad. She said it was just hard um, traveling because you got to get up and go. You can't just lay there. You got to be on the move because they were on their way back home. So, oh, excuse me, she got it on the last day. So, yeah, yeah. Not the Kraken though. They funny. She said release the Kraken.
Hmm.
I wonder where they came that with that name. Where did that? I'm curious to know about that. Okay, well, I'm glad everybody is doing well. Let's get this party started. So, welcome everyone to our Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurship, cracking, and all the other things, and the revenue cycle at large. Even your health. We're talking about vitamin D and the additional um, nutrients or supplements you need in order to make sure that it is effective for you. But really, we talk about the revenue cycle at large. So as you come in, don't forget to hit the thumbs up or like button. I'm Clarice Warner. I'm the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. Now, let me ask you, do you know what it takes to be a certified marketable medical coder? And sometimes I feel like that word marketable, I feel like it's like a three-card Molly thing where you got it's moving around all the time. But are some firm things that you could do to maintain your marketability, or at least get to the marketability, if you will. And we share that with a free email course. So before I introduce my co host, I will share with you some information on that free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Hey. So if you are interested in getting more information about the 5 steps to become a certified marketable medical coder, then check out the video description for the link. Joining me today is my illustrious co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been in healthcare for a mighty long time. Uh, in 2014, I transitioned away from bedside nursing into HIM. And in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
And a wonderful world it is, right? Right.
Yeah.
Ah, I love it. I love it. Let's see. Good morning, Crafty Coder, our on the street correspondent. Welcome, welcome. Um, Tanika says she has to work on Friday too. I'll probably be working too. I'm not even tripping, but because I'm sure Friday was supposed to be kind of the wind down, but it now seems to be the kick up. So I don't understand. I don't understand. Um, Vicky says that the Kraken was a mythological sea monster. Hmm.
And and Clarice, remember when we used to be on Clubhouse, the nurse practitioner from Texas, Sequisa, used to come in?
Mm-hmm.
Well, that's who I found this out from because she's a nurse practitioner in Texas,
Mm-hmm.
so
Mm-hmm.
they get notifications from the health department,
Okay.
and so I had screenshot what she had posted, and she was saying that hold on, the it says there's a new variant called the Kraken, which is a combo of two previous variants that binds to your cells, which makes it harder to cure. So,
Oh wow. Uh-oh.
so
So,
yeah.
you said that the cases are rising. Is it still too early about like the deaths and stuff? Because to me it seems some variants were harder on people than others. Had you heard any information about that?
I have just I've seen an uptick in actually one of my coworkers. We were talking about it this week. We've seen like an uptick in COVID cases, but I have not. I've only did. I think I had one patient who did expire, but uh,
Mm,
she was older
mm,
and then had complications, but never. I mean, was never. I don't know, but I've had a couple people, transition this week, but
mm.
I know that I'm seeing more COVID. But when I have been seeing it up until this week, it was never like, they might have like a low uh, pulse ox and they might be diagnosed with acute respiratory failure, which, um, but they didn't have to be ventilated, which was the case when COVID first started. I mean, everybody
Right,
was on a ventilator, ECMO, all of that.
right.
I'm not seeing that, but I am seeing an increase in cases.
Okay, okay. Yeah. And I used to watch when I know we had, I want to say it was daily, like a daily um announcement with a full weekly briefing from our governor and our the state public health or senior public health person that would provide the information. I miss that, like just the depth of the information that they would provide. I know we don't necessarily, I guess, need it now because we're not in a pandemic, but it would be nice to, and maybe they still have, because I know we had data. There was like graphs and charts that you can see, and it would show like week to week, month to month, what the cases were looking like, followed by what the deaths. I'm guessing that maybe that data is still being collected, and maybe, but it's probably really really hard because nobody is going in for testing unless they're sick. Nobody is doing all the things extra that we did previously for COVID. So, hmm. So
And
we just out here.
the only people that I think still accurately track COVID, because what I can tell is everybody who's admitted to the hospital gets tested for COVID.
Okay.
So that's how
Okay.
they're able to tell, at
So
least
that's
on
just
the
the
inpatient.
people in the hospital, right? So if you outside in the street, you just out here wilding, if you will.
Exactly, Vicky.
Yes, exactly. And drink tea. No, I'm kidding. Oh, wow. Yes, yes. Okay, so before we jump in, let me remind you, well, we've already started the conversation, but let me remind you that you can join in and add to the conversation. Don't be shy. Your opinion matters and is always welcomed here. You know what to do, just use the chat. But if you have a question, the only thing I ask is you put a Q first so that we know it is a question for us and we don't miss it. I hate when we miss questions. So just make sure you do that. So, for those who are just joining us or watching the replay, welcome, welcome. Today we are talking validation, qualifications, and compliance audits. Yes. So yes, tea definitely helps. Yes, it does. Got my three tea bag tea right here. All right, but first, let's get into our church announcements, shall we? Shall we? Shall we? Da 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 da. I don't know if you all have been involved with or paid attention to the rap beefs that has been going on, but that K Dot or Kendrick Lamar song has just been in my spirit all week. Because he said one of his lyrics was, or line bars was, sometimes you gotta pop out on them. I said, absolutely right. I just feel that in my spirit. And they not like us. They just not like us. And so I've been that's just been swirling in my head. So if y'all see some information around, they not like us. No, that's where that came from. No, they are not like us. Not at all. It's a different breed. It's a different breed. Okay, so today I want to mention, and I will definitely put it in the Patreon. It's the as soon as I heard it, I just stuck like, did he say, wait a minute? Okay, sometimes you gotta pump out and show them. Like, I can talk about it. You know, I always like I can show you better than I can tell you, but this sums that up in a nice newer way.
Did you see the clip where Drake was at a concert and he got mad because when he was walking by, the people at his concert started singing "They Not Like Us,"
No.
and he threw something in the crowd.
Oh, you can't be mad like that. Oh, he was big mad. He was mad, man. Bless his heart. You can't do that. So I will put the information about the August 2nd showing of the nurse documentary. It's in Eventbrite, so you can get your tickets early. I'll make sure that that information is in the Patreon. I think I can add it to. I may be able to add it to the description of this link. I'll add it to the description box in this for this video as well. So yeah, I can't wait. I'm all ready. We excited. I can't wait. I can't wait to see it and have our live Saturday morning tea. All of the things. So yeah, I'm interested. I can't wait. Let's see. The other thing was I am on the end of my term. Yesterday was my last business day. Tomorrow is my last official day of my presidency at the Ohio Health Information Management Association, or OHIMA. It has been a fun ride. I've had a ball. I did my farewell message, and yeah, you can check out that, especially if you're a Ohio resident or part of OHIMA. But we've had it was good. We had a good time. Now I transitioned into past president, where I'm still on the executive board and will be instrumental in some of the things that we do and the decisions that we make. But yeah, and my executive director was telling me, she was like, I think you've been the longest on the board because I've done 2 director terms, delegate, and then went into president-elect, president, and now past president. So I've been with my people for a minute, but it's been great. One of the things I didn't do, which was a goal, and I never took the time or got the time to do it, was I wanted to. We have, I think there are 4 regional associations in Ohio, and I wanted to actually physically go to each one, or at least attend a meeting, but I never got the information of when their meetings were. So that was one of the goals I wanted to do. I wanted to see the people and talk to the people. I wanted to be like president for real, see and talk. Even though I did via video, I mean, I was always trying to reach out and talk via video, and then we put together the if they had questions or wanted to contact me, the president at ohima.org email and all of those things. But I don't know. I really wanted to hear from them personally, especially as we were going through a lot of things. So it would have been interesting to hear, some of their thoughts on the state of health information, if you will. I think that would have been a great conversation starter in that realm. Were you going to say something?
So I wanted to ask you, so are you going to the conference, the annual conference in Salt Lake?
I will be there for I'm still a delegate, so I'll be there for the House of Delegates meeting on that Sunday. I'll start on Sunday. So I'll be there for 2 days. I'm not going to the conference though. Well, I don't know. Right now, I'm not going, but there may be a possibility that I do. If I get funding to go, I'll be there. So there may be a possibility for some funding. And if I get it, then I will be there.
think of it, I don't mess with Utah.
Nothing.
Nothing.
They ain't getting a dime of my money. They should have been like AAPC. AAPC was in Vegas, or will be in Vegas this year. See, that's a conference.
I don't know if they've ever been in Vegas. AHIMA. I don't know. Well, they were supposed to be in Atlanta, but COVID hit, so we didn't get Atlanta. I don't know. That's a fun time, but because I go to Vegas with the Healthcare Compliance Association, it's a fun time had by. But the conference, they do a lot. I think it depends on what's hot or what the hot topics are around AHIMA's annual convention. Because sometimes, I don't know, I think and I may be biased, but sometimes I feel like I get more out of my state. I just feel like it's more geared toward health information. Some of theirs, you get information, but I feel like it's more vendor related. So it's like a commercial, if you will, with some information sprinkled in. And then some of the things, like, there weren't a whole lot of specifics. It was just different. The networking part, I think, is really great. They have some wonderful networking opportunities. And they love to party. There are some partiers at AHIMA. There's a grand thing like that they do on the last day where they get everybody together, and it's a big party. They are some partiers, so that is always fun. But I mean, who want to pay hundreds of dollars just to go to a party? No. So I feel like sometimes it could be a little better. But again, I think they base it on whatever is going on, what the hot topics are. Their keynotes were good. I will say that. They had some really good keynote speakers there. But as far as direct education and that kind of thing, I mean, you only get so much time. It's a conference. I've never attended an AAPC one, though, so I can't compare to the two. I've never. But you gotta, and then maybe that's a meeting after the meeting conversation. You gotta give me more on Salt Lake City, so because they trying to sell Salt Lake City. When I tell you they trying to sell it, they trying to sell it. And then the last thing I have, real quick, I attended the second annual AHIMA Data for Better Health Executive Leadership Summit this week. That's where the traveling went. So I went to Cleveland, and our CEO of AHIMA, Kevin Clower, was there. Being Kevin Clower, you know how if you've ever seen him or heard him or watched him in anything, you know how he is. But I feel like he's genuine with who he is and how he acts, and so I do appreciate that. I do appreciate kind of the shift that I've seen recently and lately as it pertains to that. So this, I think their first gathering was more around, the thoughts and conversation around social determinants of health. So this is really talking about social determinants of health, how folks are acquiring that data, if they are acquiring that data, tracking that data, and what they may be doing with the data. So this session was more around vision and action. And the one thing that I will say, there were some physicians on the panel, and physicians love to take over, don't they? It's like, really? And not that it was a bad thing, but it was a couple that I was like, y'all want to know so much about health information. Y'all want to be in the health information. And maybe it was just amazing to hear some of the comments that were coming out of their mouths. Like, coders for, the claims or the billing claims and coders and making sure that they, it's really, it's really difficult. Like, we can't find ways to capture this stuff. And I'm sitting there like, you're not a coder. There have been ways to capture this stuff for years. One of the things that one of them was talking about was capturing this data and making it more about being value driven versus revenue driven. And I asked the question, I was like, I feel like we've been this road before. You tried to make it, a value driven action for providers to make sure that there's some documentation around the social determinants of health when they see the patients. But there was so much pushback because the providers were like, well, if we're not getting paid for it, then I'm not doing it. Really? So they had to kind of incentivize them with the revenue piece. One of the physicians there talked a lot about like how the E&M, so in your E&M, because it's based on medical decision making, in the one of the categories allows for social determinants of health monitoring and providing information to get you to a moderate level just in that one area. Remember, you have to have 2 of the 3 to level your service. However, it's muddy because the physician or the provider, the billing provider, has to document that encounter or document the components related to social determinants of health impacting that patient and what's happening with that patient. Whereas, there's a lot of push or talk about, no, we want, the provider, or not the providers, ancillary staff can actually document, or even patients can complete forms that discuss or talk about, some of the social determinants of health, and those can be picked up and added as additional codes in that realm. So it's some back and forth, and it's still all over the place. But it was an interesting conversation, to say the least, especially when these doctors were going back and forth over whatever. And the one thing that just blew my mind, which was paramount to some conversations we've had of late, there was one lady who was a nurse who was on the panel, and the question was asked, in this era, what type of upskilling or education for health information professionals did they think was necessary for those in the profession? What should they be looking at, or focusing on or pivoting to in this era? And the lady was talking all about health information technology, and not from a health information perspective. She was talking to us as if we were like IT people. I was like, ma'am, you don't even know your audience. Why are you up here? So that it was horrible.
That was like, when you were talking, I was like, my first question was, is she a certified coder?
No,
if
none of these. No, I take it back. One of them was. For the most, there was only one person that was a certified coder. On one of the panels. She was on the last panel where they said the topic was, you can't do this without health information professionals. But she was on that panel, and I'm like, well, how is she? I mean, because she deals with quality. She deals with quality, and she's part of a health information organization. But yeah, she couldn't answer that, and she was just talking about all of the things IT. I was like, ma'am, you talking to you don't even know your audience. I was so disgusted at that point. And then again, it reminded me of, AHIMA has to do more to educate folks about who we are and what we do. It was just, again, right there in your face, live and living color. So
I can clearly see today's theme is going to be "They Not Like Us."
They not like us.
But the thing is, that is the problem. Are we still in the church announcements?
We are, but I'm going out because we done just
all right.
took over. But this is a beautiful segue into how they are not like us. Wait a minute, let me get this out. He was like, "Are we still in the church announcements?" Those were part of my little church announcements. Let me get the music out. Okay. um, but yeah, this is just crazy. So, um, to segue into um, they're not like us. I guess that could have been the title of our stuff today. Um, Mr. Jesse, I'll let you talk about the information that you found on the clinical validation versus uh, DRG validation and who they felt was qualified to do it. Like, really?
Okay, so I was doing this past week. I was doing some CEUs because I was in this mad rush to use my HEMA tokens before tomorrow, so I have some more to do today.
I am too. I'm picking mine up too today. So if you are a HEMA and you got make sure you get them CEUs, they free because they're gonna offer some additional ones. So that may mean you can get more this particular year because of this transition. So take advantage of the transition period. Go ahead.
So I was doing one of the courses, and it was interesting. It was talking about it did a whole lot, but it revolved around like denials and clinical validation and all this kind of stuff. So in this one particular course, there was a slide that talked about DRG validation versus clinical validation, and the slide said
Wait a
that.
minute, hold on. I got it. I got it. Hold on.
Okay.
I got it. I got it. Do do do. Okay.
And it says that clinical validation is performed by a clinician, which RN, CMD is clinical medical doctor, I think, or a therapist. And then it says clinical validation is beyond the scope of DRG validation and the skills of a certified coder. This type of review can only be performed by a clinician or may be performed by a clinician with approved coding credentials. Now, I was I was just beyond PO'd when I saw the slide. That's why I screenshot it and sent it to Clarice. Because how is an organization like a HEMA saying basically this is part of what you do in HIM, but you're not qualified to do it?
Mm,
How? In what world?
mm,
And I would have said, I'm telling you, I would have felt a whole lot better if they had said can only be performed by a clinician with approved coding credentials. But just
right.
because you are and then let's get into this whole like, I was just over the moon and I was just PO'd on a whole lot of levels because this whole like RN thing is wearing me out too. Because it's just this is nothing but another level of gatekeeping. This is all it is. And I I don't and they don't provide any kind of rationale. I don't if you are in an HIM program, which you in order to be eligible, let's just keep it on a HEMA. To be eligible for a HEMA, they have a whole list of either credentials you can have before you sit for the exam or skills and knowledge you need to have before you sit for the exam. So if you have had anatomy, physiology, pathophysiology, pharmacology, why can't you clinically validate? Because when you are clinically validating, all you are doing is analyzing criteria.
Exactly.
Period.
Exactly.
You're not
Exactly.
diagnosing anything because nobody can diagnose except for physicians and non-physician providers.
Mm-hmm.
You are only validating what is in the record. If
Mm-hmm.
you see that somebody has acute congestive systolic heart failure, you can be trained as a coder to look for a reduced ejection fraction on an echo, to look for an elevated pro BNP level. to look for some kind of like lower extremity edema or some kind of shortness of breath or cough. You want to look for how is it treated? Were they treated with IV Lasix? Why do you have to be a clinician to know that that's the criteria for validating acute systolic heart failure? Why? It's
And AI are not coders, and they're talking about having AI pick up some of this clinical validation piece. I don't get it. I don't understand. Um, when you sent that to me, I was like, is this like is this what everybody is feeling? And I know this was based on the 2013 RAC scope of work, but I looked up some other uh, resources to see what their thoughts were. And there was an article in the Walters Kluwer um, by this is by a physician who is also a certified coder. He has a CPC as well, and in his article he says clinical validation is the process of determining whether a condition can be reported based on documented clinical information that meets clinical validation criteria. The requirements for clinical validation overlap considerably with medical coding requirements. However, coding professionals have met their objective once a condition is reported based on adherence to coding guidelines. Clinical validation takes this one step further. Coding guidelines and clinical validation criteria must be met for a condition to be reported. While clinical validation requires more clinical knowledge than coding, it may be performed by a wider range of professionals, including coding professionals, clinical documentation integrity professionals, um, registered nurses. I know I heard that. Health information professionals, physicians, and others. So they're not putting in the box that or bumping coding out of the mix. Again, according to him and us and those who do this work, we we should be in the fray. We're part of being able to ascertain what clinical criteria is available or being able to validate. It's like an audit. You here's the criteria. Check the documentation to see whether or not it's there. Period. Period. Now, where in this article he mentions some things where it can get, I guess, a little murky, is when there aren't standardized um, clinical criteria for certain areas, then that can make it a little challenging, and you would have to kind of dig deeper and rely on kind of, I guess, universal or maybe even pair specific criteria, but still it can still be done once you have the information. It's still, here's what
it,
it says that you need, and does the documentation state that
it doesn't matter how murky it gets because whenever you have a question, that's why they have
for your
something
query?
called
Yeah, yeah.
exactly. That's why you have something called queries. Then in your query, you ask when you're asking this provider to make a decision about this condition, because I do it on my queries. Please indicate clinical indicators. Period. What's so hard about
Mm-hmm.
that?
Right. I don't understand. Again, and the crazy part is this coming from a HEMA. This is coming from a HEMA. So in your educational domains, I haven't researched them for the purposes of our discussion today, and maybe I should have, so I can bring that up. There should be something in there that discusses the clinical component of this particular um, credential, specifically if you've gone through their college courses or whatever. You have to, or even not so. I mean, I think I'm not 100% certain what the like certification or the certificate programs require. If they actually also require, they should
They do.
also require like your anatomy and physiology or that kind of stuff. They should if they don't. Okay. So if that's part of your curriculums and the domains and the things that folks need to check off, then why would you stand behind this as this is not something that they can do if they're being taught to do it? I don't understand that.
Because all you're doing as an organization is pigeonholing your members. That's and then you wonder why there's so much tension between coding and CDI. Because the thing is, neither one can function without the other. Because
Correct.
it's it's just it's ridiculous, and I see the the real world ramifications of this every day. I see it just as clear as the nose is on my face. And they are missing the mark entirely. They are alienating people. And at the same time, they're alienating people. They are emboldening the wrong people to think that they know more than other people.
Mm.
And
So
that's not it.
do you think so because of the overlap, particularly in the CDI departments, do you think everybody should stay in their lane? So or should they all be working together and utilizing the skills that they both should have for this type of work? For example, like if your RNs are working in CDI or your nurses, period. I won't even uh, uh, cut that line with RNs, LPNs, all of that. Nurses, period. Um, but they don't have the true coding skills, or they don't have coding certification. Um, should they just stay in their lane with what they know to do as far as clinical validation, and then rely on the coders with their coding skills, and vice versa, coders relying on their skills as coders, and then uh, handing off to a nurse the clinical validation? Or ideally, would it be best practice that everybody comes to the table with a mixture, a combination of both? Okay. Okay. So that would be ideal.
Because I was just having this one of my coworkers, mad respect for her. She's been in CDI and she was a CDI director for like maybe like almost 15 years now. And she, so she says frequently, well, CDI is not coding. So I told her, just this week, I said, you say that all the time, but how can you assign an appropriate DRG if you don't know coding? You can't. And I told her, I said, I don't know how CDI started because I wasn't around. I mean, I wasn't working in CDI when it was started. All I know is right now, today, I could not be as good at my job if I did not know coding. It would be impossible. I don't really have like these, like, there's a lot of back and forth between CDI and coding. Not on my part, thank God.
Mm-hmm.
I very rarely, and of course, and it's always good to have another set of eyes to look at
Mm-hmm.
anything. And sometimes, or even like a discharge summary, I might not see somebody before the discharge summary is completed, but the discharge summary, they might put some craziness on it. So then the coder will say, oh, well, this was on the discharge summary, but you didn't code it. Or this is on a discharge summary, but there's no, there's no documentation. So they all have already done clinical validation when they come to me and say, well, we have to, can you query for XYZ? And then
Mm-hmm.
sometimes, if in the perfect world, you query for everything while they're in house. So when they're discharged, everything's easy peasy and spelled out.
Mm-hmm.
For 99% of my cases, that's how it works. You see something, okay, well, and you'll give it like a day or two waiting for the attending to go see the person again to see if they're going to update it. But they copy and paste the same note continuously. So you have to come out and outright ask, Okay, well, I didn't gave you, look, you didn't already seen this person. You still saying the same thing. Infectious disease that said that the chest x-ray is negative. This person doesn't have pneumonia, but you still have it on there. So then you send, a query, for that. But I don't know how, like for instance, it doesn't matter what kind of clinical skills you have. If somebody comes to the hospital and they have a displaced fracture of their femur, fine. Okay, you could be an ortho nurse, fine. But if you're reading that chart and they have a past medical history of osteoporosis and they're on some kind of, let's say, a weekly medication,
Mm-hmm.
if you don't know that osteoporosis and a fracture gets coded to pathological and you code it to traumatic, you have already messed. You
I
playing with the
messed that all
church's
up.
money.
You sure did. You didn't mess that all up.
No amount of floor nurse experience is going to teach you that.
Yeah. Yeah.
You cannot do CDI without knowing coding, and especially in this day and age. And anybody else that says that you can do it, I'm telling you, tell them Jesse said you lying.
Wow. Interesting. Interesting. I don't know. I I don't know. I feel like we're in a position to kind of solidify the definitions of these roles, what folks can do, um, or should be at that point before we now add this additional layer of, because that's still irking me, what's considered unnecessary coding task or unnecessary task that's is still haunting me in the background. And so I feel like before y'all start slapping on, oh, AI is the end all be all that can do all of these things, even they say that first, and then they say, oh, but we're going to still need some human intervention or interaction with review and validation. Well, I think you need to be real clear about the expectation of what the human person should and can do, um, as opposed to what AI is supposed to do. And I think we're at that point now. We're probably past the point, but we should at least be playing catch up to make sure that those things are clearly defined by everybody, so everybody knows, before adding this additional layer of saying, okay, well, all of this can just be pushed over to AI, and then it'd just be a whole hot ass mess. I don't know.
But the thing. Well, I think I'll probably go more into this in the meeting after the meeting. But um, I met with the AHIMA data analytics director this week, Thursday,
Okay.
and the thing that is missing in HIM is like the reason why Actus exists. Actus is a pathway for nurses to get into CDI. I didn't understand why they made such a big deal over you having to have 2 years experience. But once I started working in it, I see why. Because it takes it takes a nurse who has no clue about DRGs, no clue about coding. It takes them 2 years to have a clue. They don't learn it, but to have a clue. Trust me, they don't. But they have more of a clue, and they have enough of a clue that in 2 years you can sit for an exam and pass it. Because basically the exam is focused on, because I bought the study guide just to see. The exam focuses on the major conditions that you have in like acute respiratory failure, clinical indicators.
So this is
Um,
for the active CDI
yes,
certification. Okay.
for the
Okay.
CCDS.
Okay.
So if you have 2 years of on the job training, you should be able to pass an exam.
Correct.
But where's the pathway for an RHIA or for an RHIT or for a CCS or for a CCS-P to get into clinical documentation, to get into CDI? What's their pathway?
So their credential is no longer. Didn't they have a CD? I'm sorry, but didn't they have? So I wonder what's going to happen with that credential, or how are these credentials? going to mesh now that HEMA owns HC Pro, who is over Actis.
I don't think they're going to go anywhere.
Really?
I just think that um, because it's because the clinical pathway is the clinical pathway.
So, do you have to be a nurse to be in Actis to be a member, or do you have to be a nurse to take their certification?
No, you don't have to be a nurse, but you have to have 2 years of verifiable either inpatient or outpatient experience.
Of CDI experience?
Yes,
Okay. Okay. So again, I wonder how they're gonna what's gonna happen with those.
but we talked about this before. But according to Actis's own data, um, 75% of their members are registered nurses,
Mm-hmm.
and only 30, less around a third of their members have a coding credential. Most of them only have their CCDS, and it's it's not it. They have the bottom line is they have carved a niche for themselves, and through them carving out a niche, there should be a HEMA should have a niche for their members to get into CDI as well, other than just having this CDIP credential. What does that mean?
Mm. So there needs to be some advocacy around um, the health information professionals in this particular um, track, if you will.
Yes,
Okay.
because it's starting to become well. They're already gatekeeping it already.
Yes. Mm-hmm. Clearly. I mean, if you look at even like some of the job descriptions or whatever, they're nurse or RN or whatever, that, and
And
so
you have
that keeps folks who may be interested in it from not necessarily pursuing it because you see that. But then again, who's pushing or who's advocating um for the health information professional who is a coder to be able to get into that path? Who's pushing for that? If you're saying, oh, it's for nurses, I didn't the little pathway wheel thing that we saw in didn't it say something about nurses on there when we looked it up? This was several
yeah,
episodes
yeah.
ago.
We're, oh, this is definitely for the meeting after the meeting, but I talked to the director about that wheel too.
Yeah, it's like I remember, like, whoa, 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 wow! It says on here about being a nurse, so interesting, interesting. All right, well, we will continue this on with the meeting after the meeting. I wanted to quickly talk about this report on Medicare compliance article that mentions compliance audits are based on risk assessments, which drives early claim reopening. And the crazy part about this whole conversation is that so the MACs are reopening hospital claims based on information from the OIG before there's an overpayment finding. And I, I don't know where the folks were back in what was it, 2003? Yes. So the Medicare Prescription Drug Improvement and Modernization Act, or MMA, of 2003 directed CMS to replace Part A fiscal intermediaries and Part B carriers with what they are now calling the Medicare Administrative Contractors, or the MACs. So CMS procures all MAC contracts according to the Federal Acquisition Regulation. So what that did was allowed both sides of the house to be seen. Once upon a time, before 2003, only hospital stuff went to fiscal intermediaries. So all the reviewing and claim submission and all of that stuff was done solely by an FI, and all of the provider stuff was solely done by a carrier. Well, when the Macs came together, everybody's stuff was seen. So what happened at a hospital could the claims and information that was obtained by the MAC from the hospital side of the house, you can clearly identify, well, who was the provider? And then dig deeper to say, well, wait a minute, the provider did so and so and so that impacted this hospital claim. And now we can actually look at what's happening with this provider. And if necessary, start reviewing this provider's claims. Everybody knew that. Maybe everybody forgot. So this has been since I remember when it started because folks was like, oh. So now, if and vice versa, if an inpatient something was going on with a provider's inpatient um, claim that impacted the hospital that may have been in error, then they could see both sides to see, okay, well, they did it right, but this one didn't, or this one impacted this one, and so they're both wrong. Let's go recoup. Um, I was just shocked. Like, I guess folks don't remember that when all of this happened. But one of the things that they talked about in this article is this really is that the OIG relies on their own risk assessment. And their risk assessment is pretty much based on a couple of things. One being this hospital compliance dashboard that they have that includes data for all hospitals, and they can see where a hospital can be an outlier with respect to certain type of claims. Um, and again, this is an article from the Report on Medicare Compliance by Nina Youngstrom. It's a real good article. It is linked in the description. But they also talk about what goes into the risk assessment. And I believe, and again, this is my compliance hat on, that all entities, not just hospitals, but your providers, even if they're independent providers, all entities should have some sort of risk assessment annually to determine what someone should be taking a look to see, well, what's happening with our stuff, what are we outliers in, or where do we have gaps, so that you can prepare for possible things, and you can kind of do that based on information provided by the OIG or CMS, who says, this is the stuff that we're looking for, these are the things that we've seen. You can check to see, do we have a risk in those areas? And if you don't, great, fine. If you do, maybe we need to dig a little deeper and then provide appropriate education. So,
But small, especially small and some medium-sized practices, depending on where they are, well, actually most of them, doesn't matter where they are, they don't have the money for the staff to analyze that kind of data.
but they should. They should. At some point, they should have somebody, because they ain't gonna have the money to repay it either, but they will. So you need to weigh that cost. Do we invest in making sure that we're okay versus do we save up to repay? Because one way or the other, if there's a problem, you gonna have to repay it. Um, so some of the things that go into the OIG's risk assessment is, again, that OIG hospital compliance dashboard, data from the comprehensive error rate testing contractor, and again, all this information is readily available to folks. Um, I think they're starting the Pepper reports back. So the Pepper reports, all the information and results from audit or the RAC recovery audit contractor reviews, and then input from CMS, and then they also talk to other folks who are part of the OIG, like the Office of Investigations and the Office of Counsel. So all of those things go into their risk assessment to determine whether or not um, they what they need to go after or what they need to take a look for. And so one of the pushback that, and we've heard this in a couple of the cases, the repayment cases, that the hospitals don't really like that the OIG uses independent medical reviewers um, and statistical sampling and extrapolation in their provider audits. And they don't necessarily like that they have external coders either. So uh, the person who was interviewed from the OIG said that their OIG auditors are very smart, highly educated, and well trained in performing audits, but they aren't clinicians and they aren't coders. So they contract out with clinicians and coders to perform that part of the hospital compliance audits that they don't have the expertise to do in house. Um, but
And
go ahead.
and when they talk about they don't like how they do statistical sampling, how else can you review a payer that has 10 million enrollees but statistical sampling?
Exactly.
Like
Exactly.
that's crazy. Go ahead. All right.
Exactly. um, and then they also hear that that the hospitals feel that their medical review contractor is substituting their judgment for that of the physicians who provided the service, and that they can't question the claim because they can't do that. And he says the medical reviewers are not obligated to defer to treating physicians. Um, there's no legal presumption that hospital claims are correct. All claims are subject to audit, whether it's by the OIG, the MAC, or any um, other contractors. It's the clinicians in the hospitals who have hands on the patient, who talk to the patient and make the diagnosis and decide what treatment to provide. But that doesn't mean that the OIG can't question claims. The roles are different. Physicians exercise their judgment in diagnosing and treating patients, but they also have a legal obligation to document their findings, while medical reviewers exercise their judgment in deciding whether the hospital met Medicare requirements based on the documentation. At the end of the day, it's all about the documentation that we talk about all the time. They also said this is where compliance officers can make a very big difference and impress upon the physicians in their hospitals that they must well document the care they are providing, because if it's not well documented, the claim based on that care could be questioned. So I just wanted to bring to folks' attention what is happening, always happening, and how that the OIG are using risk assessments to assist them in kind of looking at these claims from the hospital as well as the providers that are supporting them. And as we've said a gazillion times, it really all just comes down to the documentation. And I, I don't know. Uh, what is it going to take for folks to understand? You got to put it down. Folks can't magically try to understand what it is that you're saying as it relates to these, just treating your patients.
Because what they're trying to do, their defense is, and we talked about this last year when they had that whole University of Pittsburgh Medical Center.
Mm-hmm.
Their defense is to pick at the qualifications of the people who
Mm-hmm.
caught you in your foolishness.
Mm-hmm.
That's not the best defense is to get your sugar honey iced tea in order.
Offense, right?
Exactly.
Exactly, exactly. And making sure your documentation, because if your documentation tight, rest assured, you come on in, look at whatever you want to look at, do what you want to do. I know my stuff is what it is. It's easier to make sure your stuff is together on the front end versus trying to figure it out, scramble, look for it. You can't be making amendments, you can't be doing all of that stuff after the fact, but it's good to make sure your stuff is done on the front end. I don't know. So that was the things I wanted to bring to your attention as it relates to validation, qualifications, and compliance audits. So, I guess my one takeaway, or a couple of takeaways, I guess, related to AHIMA is we need some for real advocacy related to um, our profession, not only in certain areas, but really in all areas. Let the folks know who we are and what we do, period. And then to our provider community, please document your stuff. So, I mean, this can all be so simple. Just
Good
document your
thing.
stuff. Just
Good thing.
document. But and like you said, they don't want to pay a person, uh, even in a smaller practice, but they're gonna pay the attorney to try to get them out of it. I, I don't, I don't, I don't know. But here we go. Here we go. All right, all right. Well, that's all I have. Mr. Jesse, did you have any additional comments or
No.
no? No.
Well, I do, but they're for the meeting after the meeting.
Therefore, the meeting after the meeting, which will make me slide on over here. So, did you know that becoming a Patreon of ours, you are joining a community of individuals who share a deep appreciation for the intricacies of healthcare revenue cycle? Yes. Here's what you can expect as a value Patreon and a member of the Tea Sippers. That's what we're called, the Tea Sippers. Exclusive healthcare insights. You can gain access to in depth articles, webinars, and resources covering the latest healthcare trends, compliance updates, and revenue cycle best practices. Early access. Be the first to receive expert insights and guides, ensuring you stay ahead in the ever evolving healthcare industry. Personalized support. Enjoy direct access to our team of experts for guidance on medical coding, compliance issues, and revenue cycle management. We're here to answer your questions and support your professional growth. And last but certainly not least, community connection. So join a private community of healthcare professionals where you can network, share experiences, and collaborate on finding solutions to common challenges. So by supporting us on Patreon, you're not only advancing your healthcare knowledge and career, but also contributing to your success and becoming a resource that empowers health care professionals like you to thrive in their roles. Again, thank you for considering becoming a Patreon. Check out the link in the description of the video. You can also go to patreon.com/Clarice Warner, the girl with the pearls. Your support means the world to us, and we look forward to helping you excel in the world of health information. So, we are at the top of the hour. Thank you all again for joining us this morning for the Saturday morning tea or checking out the replay. Let me ask, was the tea spilled today? Was the tea spilled today? Whether I heard something, I was watching some reruns, and he said of P Valley. Yes, I do watch that. If there is any tea you can spill, this is a direct quote from Uncle Clifford. If there is any tea you can spill, either lukewarm or scorching, I need to sip it. I said, oh, that should be part of our whole thing. So put your teacups in. There you go. Put your teacups in if the tea was spilled today. And if this information was valuable for you, help us share this message with others by sharing the video and subscribing to the channel. Be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. And as you leave out, don't forget to hit the thumbs up or like button and put your teacups in the comments. Also, check out the Coding Nurse channel on YouTube. So, again, this has been a great session today. See you tea sippers at 10:15 for the meeting after the meeting where I'm sure we're going to have some lively conversations today. And thank you all for joining us. Mr. Jesse, did you have any final last words?
The only final comment I'm going to make is I really hope that the people who watch live and watch the replay really understand, like, we, you and I are really like in it. We have direct contact with the movers and shakers in this freaking industry. Like,
Mhm.
you're going to conferences and reporting back. I'm meeting with AHIMA executive management, having conversations about the future of our profession. Like, I really want them. I want anybody to find two other people on social media that have that level of access, that are coming back and sharing with you some real insights and helping you prepare to have longevity in this career. I don't think there is.
Right, right. As well as the coding side of the world, the compliance side of the world, all of the things, CDI side of the world. We touch it all. We touch it all, and really here to give you the insight and information that you need to be able to move in your career. and be marketable in your career. Yes, yes. So again, thank you all for being here. Remember, be safe, be kind, and don't wish for it, work for it. Have a safe, if you celebrate the 4th of July, because some folks don't, but if you celebrate the 4th of July, have a safe one. And we will talk with you next time. Have a good weekend. Bye.